Your Trauma Overview, Chapter 25. So, younger people generally are the ones who experience trauma the most. So, people younger than 44, leading cause of death, mostly males. All right, they occur as a result of forces applied to the body. So, index of suspicion is an important term. So, it's your awareness that somebody is seriously sick or injured, especially if those sorts of things are underlying or unseen. You should have a high index of suspicion, which is a term I'll use a lot. And with trauma, all the injuries are due to high forces exerted upon the body. And the way that the body actually has a traumatic injury or gets one, we call a mechanism of injury, is that force applied against the body. So some of the concepts you should remember from your high school physics class: potential energy, kinetic energy, energy of work. But down here is I think it's the first law of thermodynamics: energy can't be created or destroyed, only converted or transformed. So work is that force that acts over a distance, and the work that causes injury is any of that compression or pulling or tearing of tissues beyond the limit that they can actually withstand. So this kinetic energy formula that we have here, the important thing that you should know is that velocity is more important than mass, although mass isn't irrelevant in the equation. So any potential energy is basically that mass, the force of gravity, and the height basically of a fall. There are a lot of different types of injuries you can get, and that's all dependent on the MOI. Now, an MOI that's not significant is going to be like isolated injuries to body parts. You sprain your ankle, that sort of stuff. Falls without a loss of consciousness where you land on your feet, etc. But those that are significant are going to be the ones you're going to be worried about. So it's multi-system trauma, more than one body system, falls from height. It's usually 2 times the patient's height, something like that. MVCs, motorcycle crashes, autopeds, GSWs, and stabbings. So blunt trauma generally doesn't break the skin. So it's the force that's caused without penetrating those soft tissues of your body. And penetrating trauma, you should know, it's stabbings, it's gunshot wounds, that sort of stuff. But there are varieties of MOIs for all these penetrating and blunt traumas. So blunt trauma is an object making contact with the body, even in a fall. It's basically a deceleration injury where you fall and you make contact with the ground. The ground makes contact with your body. MVCs are one form of this. It's the most common MOI. Maybe like geriatric falls, maybe more common, but we don't get called as much for those. So watch out for pain and have a high index of suspicion for any injuries that may be hidden, which is why we do that full head to toe on our secondary. And it's important to know how many crashes there are actually in a collision. There's 3. So there's basically a car against an object or another car, tree, that sort of stuff. That's going to be your first sort of collision there. What you're going to want to do is actually assess the vehicle for the amount of impact energy that happened. So you can see on this car, it's going to be a frontal in front of a tree. Typically what you want to do if you're leading the call whenever you arrive on scene on NBC is sort of walk around. For one thing, you're going to get the MOI just from the amount of intrusion and things like injuries that can happen from that MOI, things like spider webbing in the windshield, a bent steering wheel. Make sure there's not more than one patient in the car, that sort of thing. That's going to be your first collision. Now your second is going to be actually you against the car. So just because the car stopped obviously doesn't mean that you stopped. There's lots of injuries that can happen from this: lower extremity fractures, flailed chests, which we've talked about, head trauma. And the third's going to be basically your internal organs against the bony structures of your body, typically, even against each other, against ligaments that can tear it, that sort of thing. That's going to be your third collision in the crash. One of the important types of these collisions is called a coup counter coup. So you can think about this guy that's hitting the windshield here. So the coup is the first strike. It's going to be against the front of the skull, and the counter coup is going to be the back strike when his head kind of whips back. It's going to be the back of the skull making contact with the occipital lobe of the brain there. That's going to be a coup counter coup. And you should know what these sorts of injuries are, a coup counter coup. So a lot of these are going to be criteria for like priority one trauma patients. It's going to be the death of someone else in the vehicle. That should clue you in that there's a high MOI. Deformity of vehicles, such as deformity of steering wheels, a lot of intrusion in the vehicle, severe damage in any part basically, but from the rear, sure. Ejections from the vehicle, always high MOIs. Rotational forces and crashes, things like rollovers or where they just spin around. So on frontal crashes, just like in all crashes, make sure that the passenger was restrained. Ask them if they're wearing their seatbelt. See if the airbags actually deployed. Which ones? Was it the driver and the passenger? Were there side curtain airbags deployed? That sort of stuff. The purpose of those are to try and prevent or lessen those second collisions that occur. Now, even if they're airbags, suspect injuries to things like extremities, internal organs from the third collision, that sort of stuff. So just because airbags deployed doesn't mean that someone's going to be totally safe. Now, you should know that children should always ride in the rear seats here, unlike what we did when I was a. And one safety things, which is something that the fire department trains on extensively, that if an airbag didn't deploy, don't be sticking your head in that vehicle in between the patient and the airbag. All right, because you can get seriously injured doing that, and they can go off at any time. This guy here has a seatbelt sign. So even these sort of seatbelts can injure people. And you can see on this guy, he was the driver, right? He's wearing his seatbelt inappropriately because it's over the top of his abdomen here. That is not where you wear that seatbelt. It's called a lap belt for a reason. So usually when you call into the hospital, you're going to tell them there's a seatbelt sign here, and that's what this is. Right on frontal crashes, look for contact points that the patient's going to make. So look around the interior and see what could happen. So what's important about frontal impacts, and a lot of them in general, there's generally two places the patient can go. We call these either an up and over or a down and under impact. So I'm showing you an up and over here. What that means is he goes up and over the steering wheel. So the chest can impact the steering wheel, and then the head can impact the actual windshield. Now, their legs and feet can also be involved in these sorts of accidents where their knees, their legs strike the dashboard. And one of your clues to this is going to be a spider webbing where you can see where someone hits the windshield. Sort of like this guy here. These are the types of fractures that can happen. You see on the frontal bone here, he has a huge compressed skull fracture. He has a linear fracture there on his skull too. He also has facial bone fractures here. So you can see here where it actually fractures around the orbit here, the zygomatic arch, the maxilla is displaced, and basically this entire frontal region, the patient is now free floating because his nasal bone also fractured here, which is why we tell you to palpate someone's face. This is called a Lefort fracture. It's a Lefort 3, I believe. And again, counter coup, just a different kind of picture here. These sorts of things happen in front end collisions, rear end collisions as well, rollovers, all sorts of stuff. So the first impact on someone being rear ended here is with the back of the skull. And you see this sort of occipital lobe where it contacts the back of the skull. And when his head kind of whips forward here, the front of his skull here is now affected as well, or the front of his brain is affected as well. This is going to be your down and under sorts of injuries when someone, they don't have to go over the steering wheel, they can actually slide under the steering wheel as well, so they can hit the dashboard with their knee. A lot of times what you can find here is these straight sorts of hits on these dashboards can fracture midline femur here, sort of its weakest point. The femur is a pretty strong bone. Now they can also strike their tib fib as well, or they can have these sorts of crushing injuries here where the floorboard comes up on them and strikes the tib fib into the knee, and the knee strikes the dashboard, and then you have bilateral tib fib fractures. You could also have things like hip fractures and dislocations where their knee hits, that sort of stuff. So that's a down and under sort of MOI on this. Now, the important thing about rear end crashes, according to your textbook here, is going to be these whiplash type injuries. These are typically caused by not having a headrest or having it too low on your car, so it needs to be actually placed in the appropriate place. And what whiplash is basically extension and flexion of the neck here that causes the injury. So when someone is rear-ended, propelled forward, right, and your neck and head are left behind, which is why you have this sort of extension injury here. And then there's an acceleration type brain injury. And the more whiplash you have, the more likely you're going to have it on a later accident. Now, lateral crashes, think about T-bones, broadsides, basically side impacts. They're a very common cause of death with MVCs. Now, this side impact, so we're looking at a passenger here. There's all sorts of points of contact this person can make. So when there's intrusion here and someone is hit, their head can strike the windshield, right? This is why side curtain airbags are there. Their arm here can cause clavicle fractures, arm fractures to the humerus. Side impacts can also cause things like rib and liver injuries, and then hip fractures, pelvic injury. You can also have some sort of lateral whiplash injuries with this as well, with flexion extension of the neck. And just like that picture showed, when there's broadsides here, lateral crashes, suspect things like chest and abdominal injuries, fractures from basically, your shoulder down to your tib fib, also skull fractures because they're striking the windshield. And then obviously organ damage from that third collision. Now, rollovers are typically the worst. So, SUVs we think about because their center of gravity is a little bit higher there. They can be caused to roll over more easily. Now, especially if someone is unrestrained in the car, they're going to have all sorts of secondary collisions inside the car, along with third collisions just inside their body. So here's an important sentence here. The most common life-threatening event is ejection from the car or partial ejection of the passenger from the vehicle. Rotation or spins. So they're similar to rollovers as well. You can hit and sort of pinball all inside that car, along with things like whiplash injury. And then there could be other crashes that occur. So someone struck and spins out, then they strike a light pole or a power pole or just the guardrail, anything like that. Now on autopeds, which is car versus pedestrian, they're usually very high MOI injuries. Now adults on autopeds, what's typically going to happen is they're going to see the car coming. They could be facing sideways or facing, head on to the car that's coming. And adults instinctively will turn to the side to help protect themselves. Now, pediatric patients generally do not do this. So they have some worse autoped injuries. But a lot of the injuries can be unseen. So you need to actually ask whatever the PD's on scene, fire department, the driver of the vehicle, whoever you can get, what speed they're going at, how far away the patient was actually thrown. So where the strike actually happened, what that patient hit, how far away from the accident the actual strike the patient was. Did they land on the grass? Did they land on the pavement? And were they pulled under the vehicle? So just as with MVCs, look at the car for the MOI as well. What happened? Did they strike the windshield? Did they roll over? That sort of stuff. Usually you can summon ALS backup. It's typically not needed. BLS is very good on trauma. So if you don't need ALS, you don't need to call them. You need to get to the hospital as quickly as you can. And here's the best actor in the world here on a bicycle versus a car. And you're going to evaluate it just like you would an autoped. The same thing, the speed the car was going, how far away the person that was struck is, whether or not they're wearing a helmet. Look at that helmet for damage. Look at the bicycle for damage. All these questions, what did they strike? So in these cars versus bicycle, as well as the auto ped, make sure you take inline C-spine stabilization. Uh, so a car versus a motorcycle, they should be wearing a helmet. In Oklahoma, not so much. They will be wearing leathers a lot of times, which they hate for you to cut off because they're so expensive, and boots. So look for deformity of that motorcycle the same as you would a bicycle. You know, the side with the most damage. How far the person was thrown, how far they skidded, any sort of deformity to the vehicle that struck them, where they landed, all that sort of stuff. On these sorts of head-ons, just like Isaac Newton taught us, just because the motorcycle stopped doesn't mean the rider's going to stop. So there's several kind of injuries that are common. You can see here on the left. So the motorcycle goes under the car a little bit. So the actual passenger of the motorcycle is going to continue forward and strike their head, upper body on the vehicle that's there. They can be thrown over the handlebars. Generally, what you're going to see there is things like bilateral femur fractures. Now, angular crash, the motorcycle strikes an object at an angle, uh, which is why they call it an angular crash, and they're just going to get crushed, especially in the lower extremities. A lot of times they're going to be ejected. They can go over the vehicle that they crash into, over the object. They're generally at a high rate of speed, and there can be controlled crashes, things like when they lay the bike down, but they still could be very injured. Yeah, falls. So on falls, there's a lot of potential for injury. Typically, we think of serious falls for adults is going to be more than 20 feet. It's going to be significant. And they should have several internal injuries, including broken bones. Now, when people land on their feet, generally they have less severe injuries. You can use their actual injuries to actually tell how bad the fall was. Like we said before, bilateral calcaneus fractures, bilateral heel fractures, generally high MOI events, and their legs absorb a lot of the energy of the fall. But remember, it doesn't just stop at the legs and the hip joint, it's going to continue all the way up on their spine as well. So they can still have spinal injuries. Just like this person here. This is called a compression fracture. You can see how this bone was just burst from the compression of one vertebrae in between two others. So what's important information to get is going to be the height of the fall, what sort of surface they actually struck, if someone actually witnessed the fall, where they actually hit. Even from standing, these questions are important. So, did they go straight down? Did they hit their head? Did they land straight on their buttocks? What happened? What was the MOI of this? Penetrating trauma. So after blunt, trauma is going to be the second leading cause, but it's pretty close. So it's basically impalement of an object. And knives, things like that are going to be low velocity impacts, even though they're still deadly, obviously. And then sort of medium velocity impacts are going to be your handguns. High velocity is going to be your hunting rifles. And don't forget, after someone stabs someone, they can still move that knife around internally, causing more damage than what you can actually see from the outside. Now, if it's an actual GSW, don't forget that it can actually bounce inside your body. It can bounce off your hip, any other thing that can actually deflect the bullet and cause more damage. The bullet can actually fragment inside the body. So it may not be a clear through and through, but on all these patients, like I've told you, check for an entrance and exit wound. You don't have to know which is which, but you have to find all the injuries. Bullets produce a cavitation. So there's actually a rapid change in the pressure dynamics inside the body, where the flight path of the bullet isn't the only injury that can happen. So you can be shot in the abdomen and actually have chest trauma from it as well. So suspect serious injury to the organs because of this wound channel here that happens, and the actual cavitation that occurs, and the actual sort of shock wave from the bullet. So what we'll see here is an actually bulleted to ballistic gel here, where you can actually see this cavitation sort of shockwave thing that happens here whenever a bullet impacts somebody. So nice slow-mo there. So you can see it when the bullet actually impacts. You can watch it tumble through, which causes more damage in that wound channel that actually happens whenever someone is shot. So watch the bullet just tumble through, and then that huge cavitation that can happen. So there could be more than one type of injury here. It's going to be caused by that cavitation of the bullet's actual flight path, and then the temporary cavity that's going to happen. So don't forget that the area of damage is typically larger than what you would think on the diameter of the actual projectile used. And just like we talked about with that kinetic energy, it's going to be the speed of it more than the mass. And these tables from your book are generally very helpful on signs and symptoms. So one of the important parts of this is going to be that index of suspicion. So don't forget on things like blood trauma that there's going to be organs under where they were struck. So there could be significant bleeding even if you don't see it. And we'll go over things like pulmonary contusion, cardiac myocardial contusions, pneumothoraces later on. Right, blast injuries. This is one of the things that you're tested on, which most people don't study too hard, but generally it can come up on your National Registry written test. So blast injuries, there are mines here where we live. There's all sorts of things that can cause blast injuries, just terrorist acts, industrial accidents, that sort of thing. So we're going to go over 4 sorts of blast injuries, and you should know what these are. So the primary blast injury here, so it's due to the blast itself. So you can actually watch that pressure wave video there, because there's adult content on it, I suppose. And what you're going to find is hollow organ damage, particularly to the eardrums. Now, your secondary blast injuries are going to be from your own body or the patient's body being struck by any debris blown out. With the tertiary or 3, the third level blast injury is when that actual victim is hurled by the force of the explosion into a wall, onto the ground, that sort of stuff. Now, the quaternary blast injuries are from things around after the blast, things like hot gases. But most patients will have all sorts of injuries from all 4 types. So like I said, the hollow organs are the most susceptible to the pressure changes from that primary blast injury. I'm thinking things like your eardrums, your lungs, your GI tract. But the ear is the most sensitive. So if the person is pretty close, short range exposure, then pulmonary injuries can occur. Things like pulmonary contusions, which can cause difficulty breathing, even with all the stuff that's going to be in the air afterwards. It can also cause air embolisms in your arterial system. So things like vision changes, difficulty breathing, neurological signs, alter mental status. But your solid organs are pretty well protected against your primary blast injuries, but things like thrown objects or being thrown onto the ground can certainly cause solid organ injury. And it's important to know the most common cause of death here is going to be things like head trauma and neurological injuries. Multi-system trauma, it's just like the name sounds, it's all sorts of systems, so chest and abdomen, that sort of stuff. Transport these patients rapidly, they have a high chance to die or have later complications, is what morbidity and mortality means. Now, don't forget your main priority is your own safety, followed by the safety of your partner, and then finally the safety of the patient. So, always ask for additional resources if you need it, and evaluate that MOI. Identify your life threats. You know this. Focus on things like hemorrhage first, particularly arterial bleeds, and then your ABCs, airway, breathing. Treat for shock. Make sure you maintain that C-spine. Then transport immediately. But you should know on all trauma care, the actual definitive treatment is always going to be asserted. So what we try is for this sort of golden or platinum 10 minutes. Platinum 10 minutes means that by the time you get off scene, it's been 10 minutes or less. So always try and get a sample from the patient to complete a full secondary, and then consider ALS or a helicopter to transport this patient if you're far away from a level 1 trauma center that they need. When these patients have a significant MOI, they're unstable. These are sick patients. Rapidly perform the physical assessment. Don't be sloppy about it. And when it's non-significant MOIs, things like dislocated shoulders, single broken bones that aren't long bones, you can focus on that chief complaint. So head injuries, usually unseen for us. The main cause of death is going to be intracerebral hemorrhage, so bleeding inside their skull, which is going to cause their brain to actually swell up. So you're going to need to do several neuro examinations, which means things such as, looking into this patient's pupil for your exam with your actual light several times. So obviously injuries to the neck and throat are going to be serious. You can do things like swelling can cause you not to be able to breathe. It can also prevent blood going to and from the brain. So on all these penetrating injuries, also watch out for air embolisms. On your crush injuries, it can do things like crush your larynx, which can cause you not to be able to breathe. Obviously, you know what's in the chest, but there are several things that can happen. Obviously, broken ribs can actually puncture things like your lungs. You could have myocardial contusions. Your large vessels can be torn, and those patients will bleed out rapidly. This is going to be a chest seal, so this is a penetrating trauma to the chest. Generally, on these patients, we put an occlusive dressing, so you can see here where air can't really come back into the chest and cause an pneumothorax there. So you're going to want to do things like make sure you treat for shock, okay, and then reassess your lung sounds commonly. Make sure you watch their chest rise and fall throughout the call. So there's going to be a lot of vital organs that have blood flow that is substantial in your abdomen, particularly your liver and spleen. Now, on spleen injuries, we think about people, basically pediatrics and alcoholics. Those sorts of patients are going to have spleen injury commonly. But you also have your hollow organs, so don't forget about your intestines, your colon, and then your bladder. So your solid organs can tear or lacerate. Your hollow organs, contain things that can cause massive infection. You can have rupture of the large blood vessels, particularly the aorta, which does run down through your abdomen and cause unseen bleeding. So I have a picture here of the liver. So this is going to be a small, right, hepatic hematoma. They can have lacerations. Pay attention to this line here. It represents a ligament called the ligamentum teres, and the ligamentum teres, this ligament here, and the liver that's surrounded are of different densities. So what can happen is shearing injuries can occur because just those different masses. If you remember that kinetic injury, the mass does matter, so it can actually cause the liver to shear. So if you look at this liver, right, it had several lacerations here, but you can notice right along that line, this thing just sheared off. So massive amounts of bleeding there. Like I said, limit your on-scene time to less than 10 minutes on these critical patients, particularly high MOI patients, patients that have altered mental status, decreased levels of consciousness, any ABC problem that you can't fix, get them to the hospital as quickly as you can. So there's several sorts of trauma facilities. They're all rated. Our only level 1 facility here is going to be OU Hospital. The priority 2 patients can go to several hospitals in the area on a rotating basis. The level 1 facility can give all sorts of trauma care, anything they're going to need. Typically, like here at OU, it's a university-based hospital because they can actually conduct research. The level 2 facilities that are permanent here in Oklahoma are going to be 2 facilities in Tulsa. Those can provide basically all the level 1 care that those patients need in that area. If they can't, they will fly them to OU. Now, your level 3 facilities, things like Norman, they can provide a lot of resuscitation and stabilization. And a lot of times, if they need it, they're going to transfer these patients to a level 1 facility like OU. But that doesn't mean you can take level 1 patients to this level 3 facility. And level 4 are it's usually rural areas. They only need things like an RN here to actually be on shift. They don't need a doctor there, but they can still provide advanced trauma life support in a lot of situations. So these are a couple of things like Medevac Foundation. It's going to be organizations that provide the criteria for emergency, like ground and air ambulance. Now, our trauma centers are either adult or pediatric. The only pediatric trauma center that we actually have is going to be a children's hospital. So if the children's hospital can actually take the pediatric patient, they need to go there. And if they can't, they'll tell you and they'll send you across the street to OU. So as you know, most ambulances are going to be staffed by an EMT and paramedic, particularly in, higher levels of population areas. Most big cities are going to have them. There are EMS that's going to have, you know, two basics in your more rural area, or maybe an advanced in a more rural area. Now, the helicopters that come, they're usually staffed by a critical care nurse who has experience in emergency care or critical care on the ICU floors, and generally a paramedic. Some places it depends on where they're flying to or what sort of things they actually do. If they go hospital to hospital, they might have a critical care nurse and a respiratory therapist, for instance, because the patient is already intubated. And this is going to be the decision scheme for field triage. Consult your protocols. So the important things here are make sure you remain calm so you can stay organized. Correct anything that you can correct as far as patient injury goes, but don't do anything that's going to harm the patient. And don't hesitate to actually call our ALS backup. Okay, kinetic energy is a calculation of what? So we went over this. It's not going to be weight and speed. That's going to be the only distractor here. So don't get confused by things like A. It's going to be their mass, or as we calculate it here on Earth, usually with weight and their speed. All right, a 20-year-old male has a major open facial injuries after his vehicle struck a tree head on. Which of the following findings within the car would most likely explain its injury patterns here? So, I told you about the spider webbing of the windshield. There you go. That is the answer. Windshield is not intact. Which of the following would most likely result from the third collision? That collision of your organs bouncing around inside your own body. Effect that occurs during a high-speed frontal impact motor vehicle crash. So the answer is D. We did go over aortic tears, aortic shears in class. Which of the following most likely result of the third collision? Here you go. Again, it's D. So a young male experienced a blunt chest trauma that's severe when his passenger car struck another vehicle head-on. During your inspection of the interior of the vehicle, what would you most likely find? So, as I said, watch those steering wheels for deformity. All right, an unrestrained driver collided with a bridge pillar. So, upon inspection of the interior of the vehicle, you note the lower dashboard is crushed. During your assessment of the patient, you will most likely encounter what? So, what can the dashboard that can crush him actually do? Yeah, you got to watch for those pelvic fractures. All right, whiplash injury are most commonly following what kind of impact? And we went over this. They're rear enders. All right, death from a rollover vehicle crash is most often secondary to what? And we went over this as well. It's going to be ejection. All right, severe abrasion injuries can occur when a motorcycle riders are slowed after a collision by road drag. It's often most associated with what type of impact? And so it's going to be an ejection. So when assessing a stab wound, it's important for you to remember what. So we went over this as well. The answer is D. So the internal injuries can be worse than what it looks like on the outside, and they usually are. A 40-year-old man was standing near a building when it exploded. Right. He has multiple injuries, including depressed skull fractures, severe burns, and a impaled object in his abdomen. Now, his head injury is most likely caused by which one of the blast injuries? Yeah, so it's going to be the tertiary blast injuries when he's thrown.